Morning is Abid Malik with vPhysicians, and this is a solution to help home care providers connect with their physicians on the data end of things. So I'll just hand it off and let you get going.
Good morning. It's an honor to present in front of the Kauffman audience. Can somebody guess what the V in vPhysician stands for? Virtual is one of the answer, but the good answer is visiting. So this solution is about physicians who used to visit the patient in their home. They're not doing that anymore, so we thought we'd come up with a solution that will help the physician connect with the nurse practitioners. What vPhysicians does? It does three key things. One is that it focuses more on the business side of the practice, and that could be marketing, management of the practice, and also the financial part of it. The second thing that it does is that it brings the physician closer to the home healthcare staff, and that could be nurses and private duty people. The third thing that it does, it takes away the physician's responsibility away from that doctor and transfers that to the home healthcare staff or nurse practitioners. We have been in e-commerce business since 2004. That business didn't go well. So failure in one market forced us to get into another market. 2 years ago, I met with this physician in Chicago. He wanted to make his practice paperless. I thought this was a good opportunity, so we worked together in a way that he ended up getting additional patients, and my company ended up with the technology. We have been doing the development since 2011, so we have passed that development stage. We are in a phase in which we're looking for the funding. So why we need the vPhysician, the need assessment. Number one is that patients, especially the patients who are, let's say, around 80 years of age, they don't want to go to hospital. They also don't want to go to the nursing home. So this is one of the pressing needs. The other thing is that if you know the patients who end up in the emergency room, the cost is exponential. So the goal is how you provide the tools to the physician and the hospitals in this case to keep the patient home. Because if you do the 10 visit at the patient's home, that offsets the cost for a day in a hospital emergency room. The third thing is that it brings the efficiency in the practice. There was a recent report that was issued by Medscape. The idea was that 10 to 20 hours a week, this is what the physician spent on the paperwork and the administrative task. So if you can take away those administrative and paperwork tasks away from the physician and pass it on to the medical assistant, that will be great. And also, as I mentioned, in 1960 or during the 60s, 40% of the physicians, they were visiting home, and that number is down to 1%. So there is a disconnect between the physician and what's happening to the elderly patient in their home. This is the market size. We got a lot of elderly patients who are in that category, and their number is increasing, it's not decreasing, for two reasons. Number one, the medications and the technology in the medical is keeping people alive for a longer period of time. And number two, the baby boomers. The Medicare expense is about $558,000. This is what the government spent in the last couple of years. This is where we are, about $558 billion. Out of that, the patients who are in the long-term care, we estimated about $65 billion. This is what the Medicare or the government is spending in that area. Now, where we are, we know that there are a lot of EMR applications, about 373. I mean, it depends on how you count it, but this is where we are. In the home health industry, we have about 92 home health care applications. So what we're doing is, in order to bring the physician and the nurse practitioner together, we have to come up with a solution that works for both, for physician and also for the home health staff. Now, these are the screenshots that I'm going to share that with you. Number one key feature is that the clinic website and the back end, which has the EMR and practice management application, we have fused them together. On the front end is the website, and on the back end is the medical practice management application. The web pages are search engine optimized, so we didn't have to pay to anybody to come up with this ranking on the Google there. So if you type, for example, this keyword, and there are other keywords that you could use, and we will still come on the top. And that was all free. This is basically the dashboard. When you log into the back end, this is what you see. As you can see, there is a patient appointment exam. And also we have a project and task manager to manage the practice better. And this is very robust. I don't have a time to go through it. And then the document, like x-rays. If some of the nurses, they cannot write into the EMR application, they can always scan the exam and they can upload it. So this is the area you could find those paperwork, and also the billing portion. The number one need of a practice is the billing, because this is where they lose a lot of money. As you know, the engineers and the physician, they are good in what they do, the technical part, but they are very weak in the financial and the marketing and the other areas. This is the patient chart. Now, one of the features that we also have is that we can take the patient data, whether they are the current patient or the future patient, we can project that on the Google map, and then we can see if these are the current patients or the potential patients. This is the CRM portion of it, where we can keep good relationship with the patient and acquire the new ones. Because it's a web-based application, it's tablet compatible. What that means is you can take the tablet, you can pretty much work with it. This is my contact information, and I'd be glad to answer any of the questions that you may have.
Yes. Will you provide these services to other than elderly patients?
Yeah, that's a possibility, but our main focus is the elderly population. So let's say if somebody is disabled, it could be even a child that is homebound. So yes.
I've been on a long journey from a McGovern Democrat to a conservative Republican, but I got to ask, why isn't Medicare funding this if it's going to save so much money? Because all the old people want that. They want house calls.
That's a good question. I'm not a politician. I wish that people could, and it depends on who you ask. If you ask some people, they say, no, the government should be spending money on the health care. The other people will say, no, it should be privately funded. But if you look at the people who are retired, not all the money is coming from the Medicare. They have their retirement income. They have some assets. So Medicare mostly funds the clinical part of it or the health part of it. But there are some other services that these elderly people need, and that has to come from their own pocket. But I'm not sure if I have answered the question on the Medicare, because this is a little bit more political.
Ask them for money.
Okay.
They've got it. They're going to have more next year.
Good question.
Sorry, I didn't know. No, I was wondering if there was some type of a security type protection that would allow for the individual themselves and their family members in order to constantly have access to this. Maybe you answered that a little bit earlier, but family members usually are the ones that end up catching errors that medical professionals make, and I've experienced that repeatedly.
Good question. If you look at the top right, there is a patient login. Now, because we have been an e-commerce business, our responsibility was to protect the customer's credit card information. So protecting patient information is a lot easier for us. It's called PCI compliant. That means the site has to be hacker-proof. The data must be encrypted. If a user is logged in, it shouldn't be logged in forever. After, let's say, 1 minute or 2 minutes, if there's no activity, the system should automatically log out. But not only it has access for the patients, but also access for the nurses, private duty people. And there are different level of access. It's not one access for everybody. So we do have that capability. Good question.
Are you in your rural areas?
Yes. Actually, if you are not, then we want to be. Because it's a web-based, Verizon connection is everywhere. So all you need is the internet connection and a tablet. And they are getting cheaper. So rural will be one area. Actually, one of the client that we had, actually we still have it, it's in the Grain Valley, which is kind of a semi-rural area. So it works much better.
I mean rural, like in the middle of campus.
Yes, we would like to be there. If you have any connection, if you have people over there that we can talk to, I'd be glad to talk to them.
But could you explain a little bit more about geocoding? So the practitioner that's going to go out and set up calls during the day, maybe they get the information the night before. How does it help them?
In relation to mapping them and how to route?
Yes, the
Okay.
efficiency aspect.
Yes. As you know, the UPS and FedEx, they use that a lot. So let's say if they want to deliver items to, let's say, 5, 6 places in a neighborhood, so they want to make sure that they have the most intelligent route. We are very close to it. Once we have done mapping of the patient on the Google map, going to the next level is very easy. So we could do that. We have not done that, but we are in the process of doing that. Because the nurse practitioner who is mostly going to the patient, she has to see at least 10 patients in one trip. And we want to make sure that we send that nurse practitioner in a neighborhood or in an area where she has at least 10 patients. And you could only do that once you map that data. Take that data and then map that on Google.
So this also provides the security aspect where somebody that's supporting that practitioner in the field would know where they're at when they've completed the call.
Yeah, that's another feature. Good question. So that you can track where the nurse practitioner is, whether she's seeing the patient or having a lunch in a restaurant. So you could track that in a real time. Yeah, that's a good question. So that comes with some kind of accountability for the staff.
I have a question. I was gonna, actually it's more of I guess a comment and a question, but have you thought about applying this, or are there any applications to this to the mental health field. And the reason why I ask that is because I happen to know some people that work in that area, and I know that there's probably a big need for something like this, if only for tracking and keeping people on their medication and whatnot. And there also happens to be an awful lot of funding for stuff like that. You have a lot of private institutions and a lot of city and state-run institutions that, particularly with respect to children. So I just didn't know if you had any applications for this in the mental health industry or field or not.
Yeah, good question. As people grow old, their mental capacity goes down. The most serious disease that they go through is Alzheimer and the other mental diseases. I mean, this is part of aging. We have to accept that. So you're right, there is a need for it, and the people who are caring for it, whether it's a physician or the nurse practitioner. Another thing is that we could also take the patient with the mental diseases and we can map that on Google so that we can cut and slice that data and then provide more intelligent information to the providers. So yes, it will help. We haven't done much in that area. Once we have at least 100 or 200 deployment, then that area will become more clear to us. But yes, there is a need for it.
I have a question about your sales channel. Is it strictly consumer search driven, and that's where all your sales come from, or is this an add-on service that general practitioners can offer and market to their customers or their patients? How do you really, what's your sales channel?
Yeah. I didn't have a chance to put that in the slide there because we were limited on what we can present. If we go directly to the provider or to our client, the cost goes up. So we thought that if we go through the channel partners, for example, the companies who already have foot in the door of the clinic or a hospital, so we can partner with them, we can share our revenue with them, and then they can help us do the deployment. We do have planned to spend plenty of money once we get the funding. We're looking for $500,000 on the sales and marketing. So yes, I hope I answered that question.
Well, when you spend that money on sales, then you'll be spending it to go after these channel partners?
Most of the money will be spent on the, creating connection with those channel partners, yes.
We have a question from the back of the room here.
So my mother is a home health nurse and has been for a long time. So I've witnessed the amount of paperwork that home health nurses have. Is this tool going to alleviate some of the paperwork? It sounded like the doctors were passing their paperwork on to the nurses here. So if you want to get a home health agency to buy in here, how will it help the nurses to be more efficient? And is there any way to do voice to text for entering in all the information into, I guess that has nothing to do with your project, but have you tested that? The idea of having them speak the notes into these databases or what have you? Yeah,
if I understood the question right, so how the medical assistant and those nurses can enter the information into the back end of the system so that the physician can see it or the providers can share that data? Is that the question is?
Well, they're already doing so much paperwork. So it sounded to me like the doctors want to be able to pass their paperwork on to the nurses. And they're already, doing paperwork into the night. So how can you sell this as a way to make their paperwork more efficient and more manageable, because it's kind of overwhelming?
Yeah, correct. I'll give you one example. One of the nurse practitioners that was working with us, she already had a tablet, and it was very difficult for us to have her change from the paperwork to go to the tablet and enter the data directly. So we made a compromise. We said, okay, what you can do is you can still use the one-page exam that we gave it to them. She had about 3-page exam, and we said, well, can we reduce it to at least 1 page so that it's easy to scan and upload that exam into the system? So she finally did that. So we thought that it's going to be a big jump asking a nurse practitioner or a physician, who is especially old physician, to go directly from paper to our system. So maybe we can ask them to still use the paperwork for maybe 5-6 months, and then scan it, upload that into our system. So yes, there is a difficulty. I mean, there is a learning curve. But there are some penalties by Medicare and other insurances that if they don't switch from paper to the electronic, then they get penalized. So these are the things that the government is doing, trying to make the practice paperless. I hope I answered that question.
We've got another one from way here in the back.
Is there a way to share the mapping data so that like the CDC can track certain diseases, such as watching how the flu spreads, things like that? I know you're mostly dealing with elderly patients, but you still have diseases like the flu that the mapping could be very helpful in watching how that spreads.
So is the question is about sharing the data for research?
Yes, it's about sharing the data. Can that be shared like with the CDC or another group that's trying to track certain diseases?
If you know, there is a EMR application out of San Francisco. It's called Fusion. I cannot remember the name of it, but it has something. They got more than $60 million funding. What they're doing is the EMR application is free. So what they do is the data that they collect, they sell it to the CDC or to any research company. It's aggregated data. Hopefully they don't sell the patient information, which would be illegal, but they can sell the aggregated data, and you could use that, or the government could use that for the benefit of the people there. We plan to do that too, but our data currently is very small. As we grow, then we can make more sense of what information we are collecting about the patients and their diseases.
I have a question that kind of piggybacks on to the nurse side. My wife is a registered nurse at a hospital, and so I get to hear about kind of all the craziness that goes on behind the scenes with having to take care of a lot of patients. And you had mentioned, I think, 10 patients in a day for these nurses. If they're doing a 10 or 12-hour day, that's with drive time, and you said you wanted to keep them all in the same location, which will help with that. Are you going to require a certain amount of patients, or are you going to allow them to stay at the residence as long as needed? Talk a little bit about the nurse to patient load.
Let's say in one neighborhood or in one area, we have 4 patients. We have no choice to send a nurse anyway because there is a need for it. We cannot avoid those patients. Or maybe we can ask another practice that, okay, well, since you have more patients in that area, how about if we refer those patients to you, and you refer patients to us that are in our area. So this is something, a collaborative thing that you could do. But one thing that we did for a Detroit clinic was the physician had about 100 patients, and he needed additional patients because there were not enough patients on one street or one neighborhood. So we helped bring in those patients to that physician, and he was very happy about it. So what we did is we created 2 layers, one layer for the existing patients and the other layer for the the new patient there. And the way you can get the new patient is very easy. Well, easy in the sense that we don't borrow that data from the hospitals or the clinic. That would be illegal. But let's say if an elderly patient goes to Walmart and buys something about arthritis or diabetes, then the marketing company or the credit card company, they tag that patient, and that patient data is available now these days. It's not openly available. You have to sign an agreement with the company that you will not abuse the data, or you will stay within the HIPAA compliance. So I hope I answered that question, is that you can bring in additional patients in that area to make it worthwhile for the nurse practitioner to see more patients in one area or one neighborhood. Yeah. Brian, you had a question?
Okay, my question is there resistance among the elderly to be seeing a nurse practitioner as opposed to the physician? And if the nurse practitioner needs to consult with the physician during a visit, is there availability for real-time interaction?
Yeah. I think last year or the year before that, there was a government requirement that there has to be a face-to-face visit by the physician. But now they are relaxing it because the nurse practitioners are saying we are as good as the physician because they have 10, 15 years of experience there. So there's always a struggle going on between the family physician and the nurse practitioner. And the government also knows, especially in the rural area, physicians don't tend to stay there. They want to, stay in the cities. So it's a very good question, especially when I mentioned that in 1960s or in the 60s, 40% of the patients, they were doing house calls. That ratio is down to 1%. So the government realized that there is a shortage of physicians. So what they're doing is they're looking the other way when the nurse practitioner is taking the lead. But there is a requirement that the physician or the collaborative practice physician has to review 10% of the charts of the patients that is seen by the nurse practitioner. It's between 10 and 20%, depending on how distant or how far is the physician office from the patient. I hope I
don't like your answer, but yeah.
All right, we have time for one more question over here in the corner, Abid.
I think you're definitely onto something. My mother's 70 in New York, and we just managed to get her a cell phone and turn her into a Mac person. Not all that generation has connectivity or even wants to. The other thing is, how have you dealt with the massive amounts of medical records, and are you outsourcing that data to be inputted, and how are you dealing with that?
Yeah, there is a standard format that hopefully the clinic or the hospital are using an existing EMR application that comes with a standard format. And now it is becoming easy to transfer the patient information, their demography, their insurance information, their diseases, and the procedure codes, the history of the procedure code. So there's a way you can standardize those on both and let the data flow in either direction there. So if we couldn't do that, or if we don't have enough fund there, then yes, we are planning to hire a third party to do that for us.